Professor McIntyre to give the first presentation.
Good morning, everyone. I'll just say all protocol observed and avoid long lists of thank yous. But just to thank AfHEA for this enormous privilege of being able to speak here today. I see that the time has been reduced on our how long we're allowed to speak, so I'm going to speed things up a bit and not go through all the slides. Last night there were wonderful introductions to why primary healthcare is important, and so I won't talk about those issues. I think just to mention briefly that one of the things that health economists have done is benefit incidence analyses and have shown that, in fact, the poorest, the services that they use most are at the primary care level. So it's a pro-poor policy to actually focus on primary health care and to target funding to that level. The other thing I wanted to briefly touch on is just to say that we really need to give much more emphasis to preventive and promotive services, because the affordability of universal health coverage is incredibly dependent on whether or not we deal with the NCD epidemic or that is going to be hitting low and middle income countries, or is already starting to hit. I'm going to just quickly go through these slides. I'm not going to talk much about them. But essentially, there are various estimates of how much we need to fund good universal primary health care. Now, what this graph shows here is this shows the current, and I'm focusing on domestic public funding of healthcare. This shows what general government health expenditure currently is in different African countries in per capita dollar terms. And you can see it's very low. Now, one of the targets that's been put forward is that we should aspire to government spending on healthcare being at least 5% of our GDP. And that's what the red bars show. It shows what we could do if government expenditure on healthcare was increased. And just to, I noted the little rivalry between Ghana and Nigeria last night. Unfortunately, I can't point to the Ghanaian and Nigerian bars here, but Ghana is doing slightly better, quite a lot better than Nigeria in this respect. One of the estimates about resource requirements is that governments should be spending at least, to get good, comprehensive primary healthcare services. There are various estimates. They vary between about $75, $80, and possibly, but to make things easy, I'm just going to put it at 100. And that shows you where we need to get to. So countries can do better in terms of government spending if they moved gradually towards the red bar. But the important thing about this slide is that it's clear that most African countries are going to be heavily reliant on international assistance to achieve universal primary healthcare services. But the problem with indicators like saying, well, we need to spend $75 or whatever to get good primary healthcare, universal, is that we tend to look at this target and then say, okay, we've got quite a far way to go. But the truth is that a lot of the money that is spent from government resources actually goes to higher level services. So if half of government expenditure on health only half goes to primary health care, then your target actually is much higher. So that's just to highlight that issue. And last night somebody mentioned that most countries in Africa are spending less than 40% of their budget on primary health care, and in some countries it's as low as 25%. So just to bear that in mind when you're looking at these targets. So the big question is, where can we get the money from? We have got to increase domestic funding and not be completely reliant on international funding. So the question is there fiscal space? Now, this basically shows that as a country's GDP increases, yes, it's able to raise more of its GDP, a higher percentage of its GDP, in government revenue. But, so there is a positive correlation, but the correlation is very weak. And you can see that it's a very dispersed map, so that basically many countries are raising a lot more as a percentage of their GDP than their GDP per capita would suggest. So how can governments go about this? And for me, one of the critical things is improving tax compliance and revenue collection efficiency. There are a number of African countries who have demonstrated how this can be done. There was a study done in South Africa, in Kenya, and in Lagos State, Nigeria, which demonstrated how, without increasing tax rates, dramatic increases in tax revenue could be achieved. Some of the key factors were giving the tax collection agency autonomy and investing in capacity, not only skilled staff, but in IT systems as well, making it easier for people to be able to fill in their forms, and also having IT connections between the tax authority and the banks, etc. Also investing quite a bit in creating a positive public perception of, we're here to serve you, this is how your tax revenue gets used, etc. And also naming and shaming those who are defaulting, particularly the very high income, the very wealthy, who are ducking taxes. And very, very importantly, zero tolerance for corruption. And I think the South African case study is absolutely fascinating. How we went from a horrible tax environment where people just were not supportive of government, didn't want to pay taxes, got a wonderful change in the tax authority, massive increases in tax revenue, and then state capture, corruption crept in, and the tax authority has just deteriorated dramatically, and again, low tax compliance. Also, a lot of discussion about innovative financing options, and certainly those can be explored. A lot of African countries have mineral and natural resources, and strong government policies around that and how the royalties from that revenue are used, and that it should be used for inclusive development investments. Once again, governance is critical. So for me, actually, that's the biggest challenge that we face. We can do it. We can increase fiscal space, but we've got to sort out some of the governance issues. Finally, and one of the most important things in terms of fiscal space is we need global action in relation to serious tax avoidance by multinational companies, tax havens, etc. So this is from the Addis Ababa action agenda, which was around how to finance the SDGs. And I want to highlight in number 23 is that there is a commitment to make sure that all companies, including multinationals, pay taxes to the governments of countries where economic activity occurs and value is created. We know that African countries lose massive tax revenue through tax avoidance by multinational countries, and I think we need to address that. So we could increase government revenue. I really believe that. It has been demonstrated. But we have also seen that very seldom does that actually go to the health sector. Health sector budgets don't necessarily increase when government tax revenue increases. And this is where health economists can play a major role. Ministries of health have got to demonstrate to ministries of finance that they are using the resources that they currently have effectively, equitably, and need to make a good case for additional resources. Even if the health sector gets more funds, how do we make sure that it goes to the primary care level? This is where I think that strategic purchasing is going to be absolutely critical, and careful management of those resources. And I think looking at things like paying on a capitation basis to the primary care level can ensure resources get there, but also that they are equitably distributed. A key thing is health workers. We've got to have health workers. There were wonderful examples yesterday of how we can improve the distribution of drugs through drones, et cetera, but we've got to get health workers, motivated health workers, to the primary care level. And I think we've got to seriously look at incentivizing working at the primary care level. So one last idea. I'm not a great fan of earmarking taxes, earmarking sin taxes, because very often the ministries of finance say, okay, well, we'll just offset that by reducing the amount we give out of general government revenue. But an interesting example is Thailand, where they added a surcharge to some of the sin taxes on tobacco and alcohol. And that surcharge has gone to the Thai Health Foundation, which focuses specifically on preventive and promotive services. It tends to be a bit of a vertical program, and I think within the African context, something that we should possibly consider, community health workers, the CHIPS example in Ghana, they are critical to ensuring access to primary care services and can have a very strong preventive promotive component as well as basic curative services. So this is something that we could possibly look at, is earmarking a surcharge on sin taxes as additional health funds, not a reduction in other parts of the health budget. So I'll end there. It was mentioned that I'm executive director of AfHEA at the beginning, so one thing I can say on behalf of AfHEA is really congratulations to AfHEA on 10 absolutely amazing years. Thanks very much.
Thank you very much, Professor Dai. We'll now invite Dr. Meriboli from Nigeria.
Gentlemen, I'm just going to address the topic of this conference, that's securing primary health care for all, foundation for making progress towards USC. But in doing that, we are going to try and look at the health reforms that are currently taking place in Nigeria. So I will start by saying that the Nigerian health system has 3 tiers. We have the primary, secondary, and tertiary. We all realize that 90% of our health problems are solved at the primary health care level. However, Nigerians' health indices have remained poor. Of course, over the years, we have tried to address issues of health using health policies that have identified primary health care as a fulcrum for our healthcare service. We've also tried to look at other reform programs that will reposition primary health care to the place it's supposed to be, with a view to helping our healthcare system improve. However, we know that there are certain drivers of underperformance of the primary healthcare system, which, if not changed, will make the primary healthcare system that we want to have, a mirage. These include things like weaknesses in the systems. We're talking about accountability, we're talking about budgeting. The budgeting sector in Nigeria, we try to give more money to secondary and tertiary healthcare facilities at the expense of the primary healthcare issues, even the human resource for health. So what has this transcended into? There is loss of confidence in primary healthcare system in Nigeria by patients, by the communities, the people that this system is meant to serve. We also have people paying a lot of money in accessing services at this level. And generally, people lost confidence in primary healthcare system. So the only way to do this was to embark on several reforms that will help us reposition primary healthcare at the way it's supposed to be. In 2014, we had a presidential summit on health, and that summit reiterated the need for primary healthcare service being at the center of achieving universal health coverage and sustainable development goals. And we also agreed that we need to provide financial risk protection to majority of our people. In 2014, too, we have the National Health Act, which is a legal, it's a legislation that has been in the coolers for a very long time before it became an act. This legislation also tries to give roles and responsibilities to the different tiers of the health system, primary, secondary, and tertiary, but particularly primary, with a view to strengthening it. We had the primary health care under one roof policy, which tries to pool the human resource for health at the primary health care under one body, with a view to ensuring that we maximize the use of the resources at that level. We also had the National Strategic Care Development Plan, which the first one was 2010 to 2015, and the second one is now 2018 to 2022, that reiterates the importance of primary health care in our national health system. We have other reforms like what we call the Nigerian State Health Investment Project, which is a resource-based financing program aimed at improving intervention, high-impact intervention of maternal, newborn, and child health in primary health care system. And we also have the Saving 1 Million Life Performance for Results. We tend to look at payment for results as against payment for output as against input kind of financing. And the present administration concentrated on what we call revitalization of the primary health care facilities. And what do we mean by that? Ensuring that the facilities have the right infrastructure, the right human resource for health, and some kind of accountability, ensuring that we have some physical autonomy at that level to be able to deal with issues of operational funding. And finally, I'm going to talk about the Basic Healthcare Provision Fund, which the Act actually made mention of in Section 11 of the Act. However, we need to understand that the initial reform, the Nigerian State Health Investment Project, had a performance-based financing and a decentralized facility financing arms. And what did we find at the end of running this program for 3 years? We found out that the program had a positive outcome on healthcare. It ensured improved access. It ensured that issues of skilled bed attendance and the outcome, positive outcome in terms of delivery, were very much true to type in the sense that we recorded less mortality, maternal, newborn, and childhood, and we also covered more services. And this is because we're able to remove out-of-pocket expenses at the point of assessing service. Again, the project also strengthened primary health care in terms of accountability and management of health facilities at that level, while improving structural issues such as supervision, because it strengthened the systems along the line, both at the federal level, National Primary Health Care Development Agency, Federal Ministry of Health, and at the state level, including the local government supervisory committees or people who do the supervision at the local government level. And this is because what to work with, infrastructure and what have you, were provided to them. We also introduced IT in terms of measuring progress, using data, using electronic platforms to see what is happening at that level. So these visible positive results helped us to say that the best thing we need to do as a country is to scale up what has worked. And this is what we brought to the Basic Healthcare Provision Fund. So if you look at the picture on the board, this is what used to happen at the primary healthcare facilities before and after NSHIP intervened. And you can see in terms of the drugstores, in terms of physical look of the facilities, and even the record section. So we believe this is the way to go, and that's what we try to bring in to bear in the Basic Healthcare Provision Fund. However, besides the Basic Healthcare Provision Fund, there are other programs like the Saving 1 Million Life Initiative that tries to incentivize performance at the primary healthcare level. We looked at output indicators such as ANC coverage, use of insecticidal treated nets, prevention of mother-to-child transmission, and we discovered that by incentivizing health workers at that level, people are galvanized into ensuring that they offer services. The Basic Healthcare Provision Fund, which we need to operationalize, fully operationalize in the next 1 or 2 weeks, is about ensuring that money reaches the primary healthcare facilities. We're also trying to ensure that they have a business plan. We're also trying to ensure that they use the community in trying to ensure that they deliver service to the people. So there is a lot of community participation. There is going to be a lot of outreach services. So all the issues of primary health care, which involves prevention, promotion, even rehabilitation, as well as ensuring that people don't pay at the point of service, will be brought to bear in Basic Healthcare Provision Fund. The government of Nigeria appropriated 55.1 billion naira in 2018 budget, which is still running, to be able to operationalize this. It's our hope that as we move forward in operationalizing this, we will not only talk about primary healthcare system, but we are seen to walk the talk. And the only way we can ensure that we move towards achieving universal health coverage is to ensure that all hands are on deck. Because besides treating patients, a lot has to go on prevention, a lot has to go on outreach services, and we need to ensure that domestic resources are brought to bear. Let me also add that in the Basic Healthcare Provision Fund, it's not only about domestic resources. There is also international donor organizations and philanthropists that we are calling to help in moving this forward. So our goal, finally, is to ensure that the money the government brings is sustainable, and that's why it's in the Act. We are hoping that every year that goes by, this will be budgeted, and this will only increase the physical space in health. However, for us to ensure that this works on a sustainable basis, we need to ensure effective and efficient use of these resources and also use it to implement our policies and plans. So primary health care is the way to go, and we believe that Nigeria is on the right track by ensuring that these reform programs work for us. I thank you.
Thank you very much. We invite Dr. Leju. Yeah.
Good morning, ladies and gentlemen. I will present in French, and my slide is in English. Je voudrais avant tout remercier les organisateurs d'avoir permis que je puisse être membre de ce panel. Et c'est un honneur. Merci, merci infiniment. Je voudrais également, devant cette première slide, demander à l'assistant si l'image leur dit quelque chose. Non. Est-ce que cette image vous dit quelque chose? C'était la conférence à Alma-Ata sur les soins de santé primaires. Et on ne peut pas parler des soins de santé primaires sans parler bien sûr d'Alma-Ata et aujourd'hui de Astana. Et ces deux déclarations qui ont été faites en 1978 et en 2018, donc l'année dernière, nous permettent de présenter deux concepts de santé publique qui, à mon sens, sont deux les plus beaux, la couverture sanitaire universelle et les soins de santé primaire. 40 ans plus tard, après AfHEA, la déclaration d'Astana vient renforcer l'idée que les soins de santé primaire sont bel et bien la stratégie idoine pour assurer l'accès à un paquet de services essentiels intégrés de qualité, répondant aux besoins essentiels de santé des populations à des coûts abordables pour elles, favorisant ainsi le respect du droit à la santé. Pourquoi la déclaration d'Astana? Eh bien parce que de Alma-Ata à Astana, de nombreux efforts ont été faits pour mettre en œuvre les soins de santé primaires. Qu'il s'agisse de la création des districts sanitaires avec la déclaration d'Harare, la réforme du financement de la santé avec le recouvrement des coûts avec l'initiative de Bamako, par exemple, la définition de normes pour le développement des prestations sanitaires de qualité, et j'en passe. Cependant, 40 ans après Alma-Ata, il persiste encore des inégalités fortes d'accès des populations aux soins de santé. En outre, les besoins en services de santé ont évolué devant la persistance des maladies transmissibles, notamment le VIH, la tuberculose et l'émergence des maladies non transmissibles, de même que les urgences sanitaires qui sont aujourd'hui très importantes dans notre région africaine, et l'exigence des utilisateurs des services de santé pour des soins de qualité qui leur sont offerts. Les systèmes de santé, pour la plupart de nos pays, on le constate, sont hospitalo-centrés et sont encore bien loin de pouvoir répondre aux besoins des populations, ceci en raison des faiblesses qu'ils ont dans leur dysfonctionnement. Les soins de santé primaires, qui prennent en compte pourtant 80% des problèmes de santé des individus et des communautés, apparaissent donc plus que jamais la stratégie idoine pour progresser vers la couverture sanitaire universelle, en vue de garantir l'accès aux soins de santé à tous et nécessitent donc des investissements prioritaires. Ces investissements doivent viser le renforcement du système de santé, la prise en compte des déterminants sociaux de la santé, le renforcement de l'autonomisation des femmes et des communautés. Les composantes de la déclaration d'Astana sont axées sur la disponibilité de services de santé essentiels, intégrés, centrés sur la personne, l'autonomisation et l'engagement des individus et des communautés, et la multisectorialité pour la prise en compte des déterminants de la santé. La déclaration d'Astana vient permettre aux pays de s'engager à investir davantage dans les soins de santé primaires en mettant en place des systèmes de santé qui soient solides, complets, en mettant en évidence les obligations et les responsabilités des parties, notamment les pays, les partenaires au développement, les communautés elles-mêmes, afin d'œuvrer pour une vie plus saine des populations basée sur les soins de santé primaires qui puissent être durables. Astana réaffirme que la santé est un droit fondamental, et c'est la Déclaration des droits de l'homme qui le dit. Tous les pays doivent donner la priorité aux soins de santé primaires qui soient efficaces et rentables pour atteindre la couverture sanitaire universelle et les objectifs de développement durable. Astana offre l'opportunité aux pays de faire des choix qui puissent être courageux en termes de politique sanitaire dans tous les secteurs, d'instaurer des soins de santé primaires qui soient durables, de veiller à l'autonomisation des individus et des communautés et d'aligner les parties prenantes, notamment les partenaires, sur les politiques, les plans et les stratégies nationales. De nombreux outils ont été développés par l'Organisation mondiale de la santé pour soutenir les pays dans la voie du renforcement des soins de santé primaires, notamment à travers du renforcement de capacités et des appuis, et cela dans différents domaines. Si nous faisons un focus sur la Côte d'Ivoire, le pays dans lequel je travaille, et sur les efforts qu'elle a pu faire en matière de soins de santé primaires, bien vrai qu'il s'agit d'un système qui est initialement hospitalo-centré, mais aujourd'hui, ils sont en train de tendre vers le renforcement des soins de santé primaires à travers le renforcement de l'accessibilité aux soins par la construction et l'équipement d'infrastructures sanitaires de premier contact pour combler les zones de silence sanitaire et rapprocher les services de santé vers les populations. Le gouvernement a instauré une assurance maladie obligatoire pour assurer la protection financière des populations contre le risque maladie. Le gouvernement a instauré des recrutements massifs de personnel de santé pour assurer une disponibilité permanente de ces personnels-là dans les établissements de santé. Et tout récemment, une stratégie de santé communautaire a été élaborée qui définit le statut d'un agent de santé communautaire et des services essentiels qu'il doit fournir au niveau des communautés. Néanmoins, il y a toujours des défis en faveur des soins de santé primaires, et pas seulement pour la Côte d'Ivoire, mais pour l'ensemble des pays. Ces défis concernent notamment l'amélioration de la protection financière des individus et des communautés contre le risque maladie par la réduction des paiements directs. Il faut savoir que dans la plupart de nos pays, le financement de la santé repose beaucoup sur les paiements directs des ménages. Il s'agit également de la définition et de la délivrance d'un paquet de services de santé essentiels de qualité, intégrés, centrés sur la personne, l'engagement des communautés dans la prise en charge de leur santé. Et un élément important, c'est de pouvoir arriver à rendre disponibles des données de qualité et les utiliser sur les soins de santé primaires pour améliorer la prise de décision en faveur de politiques plus cohérentes et adaptées. Pour conclure, on peut dire qu'à la fin d'Astana, en octobre 2018, 194 États membres de l'OMS ont signé cette déclaration. Et en la signant, ils ont reconnu non seulement l'importance des soins de santé primaires pour la santé de leur population, mais également ils s'y sont engagés. Et de ce fait, ils doivent maintenant passer à l'action en donnant suite à cette déclaration, c'est-à-dire en la matérialisant et en consacrant leurs dépenses de santé, notamment publiques, en faveur des soins de santé primaires. Voilà qui termine ma présentation. Je vous remercie.
Good morning, ladies and gentlemen. I'm great pleasure to be here. It's my 5th time to attend the AfHEA conference, which means I attended from the beginning of the inception of the AfHEA. Congratulations to the AfHEA, Dr. Chris team and the AfHEA members for the great achievement. Looking forward to continue collaboration with the AfHEA. As I mentioned from last conference, Bill Melinda Gates Foundation is evolving, continuously evolving from the proactive intervention to system strengthening, primarily focused on primary health care. Last time I mentioned that PHC-led ULC will be a thematic area in the global community. Now we are talking about how do we achieve ULC through PHC approach. And today I'm going to discuss a little bit about what the foundation is doing, about how to support global and country PHC system. We all share the same goals to improve population health. So the primary health care play a critical role on this to achieve these goals. And we can do quite a lot about improving primary health care. And the foundation is trying to figure out what the area that the foundation can add the value on top of what the country is doing and what the global community is doing. So currently, we are primarily focusing on 3 issues, and we're trying to address. The first one is how to improve the primary health care system design. We're trying to answer how the primary care system design the issue. The second one is about how primary care system is financed. And the third one is how primary care system is governed and managed. Those are 3 critical questions. Certainly, we can fall into many of our questions into this bucket. And lastly, we need data, evidence, and the capacity in order to strengthen the capacity. In terms of system design, I want to show you a slide. This is a study we did in one of the urban areas in one African country. On the left side is the public health care facility, public primary health care facility. On the right side, there's so many private facilities around those areas. Is this the idea, the optimal allocation approach to distribute our scarce resources for primary health care? We know we always struggling about the lack of resources. How to design our system, allocate the system, institution, and the human resources to make it accessible is a critical question. Another story I experienced, I went to one of the facilities in those areas. This facility covers 2,000 population with 8 staff members. So I asked the head of the facility, say, what do you need help if we could help you to improve your performance? And the head said, I need more staff. He has 8 staff to cover 2,000, and he wants to have more staff. So I turned the question around. I said, let's change topic again, ask this question again. If you can control budget, if you can use your budget more efficiently, what we can help you? He said, his answer is, please help me to cut the staff member to half. So we can see the resource allocation is not just a scientific issue, it's about the politics, it's about the policy. If we are not able to address this in critical, design issue, we were not able to use our scarce resources very wisely. Second one is about how primary care system financed. Yesterday our representative, Dr. Jean Kukavara already mentioned this figure that in collaboration with the WHO and other partners, we finally, and the first time, published some PHC expenditure data globally. We found that currently about $36 per capita per year spent on primary health care. And about 55%, over 54% of total health expenditure devoted to primary health care. You can see primary health care play a very critical role. However, most of this primary care is due to out-of-pocket. And the government investment in primary health care is only about 1/3 of their total health budget. Again, is that an optimal investment for primary health care? And in addition to the current spending, this is another WHO study we've been collaborating with them. And in order to achieve SDG goal, we need additional $58 per capita in order to achieve the SDG goal by 2030. Among these $58 per capita person, 2/3 of them should be allocated to primary health care. Are we relying on out-of-pocket, or are we relying on pooled, prepaid mechanism that are against the risk of primary health care and improve the access of primary health care? Those are the questions fundamental for our primary health care improvement. The third one is about governance and performance management. And yesterday again, Dr. Jean Kukavara mentioned that no measurement, no improvement. And this is the framework, again, in collaboration with many development partners, we have developed how to measure the performance of primary health care. And we have the framework, but in terms of data, you can see there are so many missing data. We don't have it. We don't have adequate measurement for governance, for population's needs, for performance management, for many areas of performance of primary health care. We don't have ideal and adequate measurements to measure it. This posed a significant question to our research and also policy committee. How are we able to manage what we don't know if we cannot measure it? The lastly is capacity development. And no matter what we do, we need a capacity to strengthen the system design, to strengthen system performance, and strengthen the system finance. And how do we develop a local, regional capacity? And if you look at the global experience, when people start to improve their system, where this idea come from? They normally turn to their eyes to their peers. Ghana turns eyes to Nigeria, and Nigeria want to learn from Ghana. It's a friendly competition, right? So we knew that the European has a European observatory, and Asia has an Asia observatory to facilitate this cross-country learning. But in Africa, we don't have an observatory. And last year, we, in collaborate with other partners, and developed an investment on Africa Observatory on health system and policy. So this observatory will put the Africa country as well as Africa WHO office in the center to managing and to work on this network to learn across country, not just between African country, but globally. We also brought a technical assistant from the people who used to work on this cross-country learning issues in European as well as in other regions. And we also looking forward to other development partners to join this journey and trying to promote and improve the capacity in the region in order to improve the performance of primary health care. Thank you.
As a Ghanaian, please allow me to add to the words of welcome you've received. A famous American congressman once said, there are 2 countries in Africa he will want to visit before he dies, 2 countries. The first is South Africa, for obvious reason. The second country he would like to visit is West Africa. Of course, he meant Ghana. So welcome to West Africa. Let me digress a bit and use my own personal experience to illustrate what I've just said. In 1999, I was privileged to be invited by Mr. Kofi Annan to be part of a small group of people who were asked to design the goals for the Millennium Development Goals, the MDGs. There were 14 of us. I proposed primary health care. Nobody supported me. I was the youngest, but I was seen as the most old-fashioned among them. And as you know, the MDGs ended up being created around some specific diseases and conditions. But the most memorable is in 2000, the year 2000, I'm an old person, so I like history. I was privileged to be invited with the then Director General of WHO to the G8 Head of States meeting. And this was when they established the Global Fund. We had argued that establishing a fund just for 3 diseases was a bit narrow. And what the world needed was a global fund for universal health coverage, or at least global fund for primary health care. It did not fly. I very remember, well, President Bush's response. In his usual frank way, he said, Dr. Brundtland, I respect your proposals, but I don't like it. I can understand why we need a fund to fight HIV, TB, malaria, but I do not understand primary health care. And I can't see how I can sell primary health care to the American people. And to be frank with you, the phrase universal health coverage is a known goal in the United States. And he wanted to explain that not that he does not intellectually understand primary health care, but it does not touch his heart. It touches his heart that there is a fund to fight HIV, TB, malaria, but primary health care doesn't touch his heart. And he sounded so convincing and so genuine, I believed him. Because as you know, American presidents don't lie. And African presidents are always right. To give you a recent example, I was privileged again to, when we were negotiating the SDGs, to chair the health sector working group. And we wanted to push universal health coverage and primary health care. Again, even within the health sector working group, everybody could live with universal health coverage, but a large number did not accept primary health care. So my message for you this morning is that we've been here before. Not long ago, primary health care was very sexy, but a few years ago, primary health care was not sexy. Not everybody is convinced that universal health coverage is the way to go. So we should not be complacent. We should see this as a second opportunity given us to get it right. And we must not repeat the mistakes of the past. We must rather learn from the past. So I want to leave you with 6 areas that I think we should pay attention, and fortunately, some of them have been highlighted by my other colleagues, so I'll be very brief. 1, it should not be business as usual. This should not just be a packaging exercise where we dust our old programs and call it universal health coverage and primary health care. It's not universal disease coverage. It's universal coverage for people. It's people who have to be covered, not their diseases. Universal health coverage is about 100%. As a sector, we are happy when we reach 80%. Universal health coverage is 100%. It's like football. It's either a goal or it's not a goal. We don't have 80% goal. Someone said it's also like pregnancy. You cannot be happy because you are 90% pregnant. You are either pregnant or you are not pregnant. The second area, we must pay attention to the economics of universal health coverage, and it's been touched upon. Financing is an important element, but financing is not the only issue. There are many rich countries that do not have universal coverage, and there are some poor or not too rich countries that have universal health coverage. So it's not just about more money. It's about smart and good money. It's also about efficient use of resources and to reduce wastage. I don't know, we sometimes say we can't afford it. It's not sustainable. I don't know any African country that is too poor to go to war. When it comes to war and killing each other, we can find the resources to buy ammunition, to pay for soldiers, and to pay for militiamen. The Ghanaians can understand where I'm coming from. My third point is about the importance of innovation and research. We cannot achieve universal health coverage unless we introduce innovation in the type of health workers, in how they are trained and rewarded. We must embrace technology. We need innovation in how we collect data, how we convert data to information, how we convert information to knowledge, and how we convert knowledge to conventional wisdom. We must see research and implementation as the two sides of the same coin. There should be no implementation without research. Fourth point, we must pay attention to measurement. I learned from Mr. Bill Gates that in business, if you don't measure, you never know when you go bankrupt. Someone said yesterday, if you cannot measure, you cannot manage. What gets measured gets done. We must not just measure coverage and universal health coverage and PAC. We must also be interested in measuring health outcomes. One of the criticisms against primary health care was that we were not focusing on health outcomes, how many lives were saved, but the vertical programs were very strong on measurement. My last, and this is my last point. We need partnership. Partnership at the national level, at the local level, at the regional level, but also at the global level. We must not antagonize the disease-specific programs. They have their attraction and their appeal. We must not demonize hospitals. Ordinary people like hospitals. Hospitals are not always luxury. Many of us here will spend the last days of our lives in a hospital. We need champions outside the health sector. We must recognize the contribution of academia, civil society, the private sector, and more importantly, the local community. Finally, since you are a technical, scientific community, my advice to you is please keep it simple. Remember the ordinary person, keep it simple. Remember President Bush. Thank you very much.
Thank you very much to all our panelists. We'll now create an opportunity for anybody who has a question, a comment to the panelists.
My name is Renee Lowenson. I'm from Zimbabwe, and I'm with Equinet. So thanks for the fantastic contributions, and I found them all very enriching and have no dispute with any of them. But I need to say that I'm quite worried about the model we're setting up, which assumes that we need to do more to treat people and then send them back to the conditions that make them ill. And I just don't think we can do that in the current era of non-communicable diseases, chronic conditions, etc. So I'm throwing this to Dai, because I think it's a question from international level as much as it is within Africa, but others as well. So we tend to package that as intersectoral action for health. But we know we are doing that really badly. So what do we need to do to make economics and policy speak upstream to all the other sectors that are generating the conditions for ill health in a new primary health care, the design of primary health care, in urban design, in economic investments, in production systems, in food systems, and so on? And what does that mean for public health authority? I worry about the emphasis on community health workers, because if you're going to contest mining sectors about how they're going to organize production, you've got to have ministries of health that have very strong capacities to do health impact assessments, to be able to say, we'll not register this investment unless you do ABC to prevent conditions. And so I sort of feel like we're still putting ourselves in a box as the health sector. And I fear that it's a very unsuccessful box, that we will not be able to have any kind of financing that will meet the level of growth of chronic conditions that we're going to experience. We already know that from high-income countries. So could we be a bit more adventurous in thinking about what we mean by primary health care in the 21st century, and a bit more confrontational in the same way as the environmental people are in saying resource-depleting economies actually need a new economic model? Can we not say the same about socially deficit-creating economies? Thanks.
Okay, thank you. Hi, this is Ana Maria. I am a PhD student from the University of Bonn in Germany. And I would like to gather the comments of the panel on 2 points. First, you were talking about primary health care, and the indicators you were giving to me, they sound a bit more like based on orthodox medicine, and a bit in line with what the lady said. What about traditional medicine? What about those cultures and countries that are in a great deal based on those other healthcare methods? Well, this is one, and the second one, you mentioned a lot prevention, but what about all the determinants of health, like cultural, social, and talking the same about prevention, maybe which could be the new paradigm to follow in that side. I would like to refer to the map that the representative of the Gates Foundation showed on the facilities of primary health care. And I have been familiar with a concept which is called One Health, and this is bringing health or taking care of health for animals, health for humans, and health for environment. And there are some publications that show that it could actually be combined, like vaccination campaigns for animals, but also bring some nurses so they can reach very remote areas and bring also vaccines to the children of the farmers. So I have that in mind as one example for preventive health care, taking into account also some other challenges as antimicrobial resistance, emerging zoonotic diseases that are coming alongside with the production system. So I will close now, and thank you very much.
Good morning. My name is Mohit Pramanik. I'm with Ghana Health Service. I want to echo some of the points that have been made and use the social determinants model. Within the SDGs, we know that even though SDG 3 is focused on health, health permeates a lot of the other SDGs. So, and then one of the SDGs is focused on partnerships, and target 17.14 talks about policy coherence. So I'm curious about how are we thinking about intentional policy coherence to maximize allocative efficiency, given that the primary healthcare model really does emphasize social determinants. It's not just the disease biomedical clinical model. So I'm curious as to how countries are doing it. How should we be doing it, given that we don't have that much time left for the SDGs? What could we be doing better? Because that's a key part of the partnerships that the last presenter talked about, and that's a very difficult part as well, but very important component. Thank you.
Bonjour, je m'appelle Laurent Moussango, je suis le représentant de l'Organisation mondiale de la santé à l'île Maurice. Je vais juste faire un petit commentaire. Le jour où je vais quitter l'organisation pour me faire élire ministre de la Santé dans mon pays, je vais faire une promesse de construire un hôpital à la population. Pourquoi? Parce que c'est ce qui est visible. Mais quand on parle du système, les gens ne comprennent pas. What I would like to say is that, because I saw that many people are putting the thing for translation. I'm working for WHO today, but the day that I leave the organization to be candidate in my country as Minister of Health, I will give a promise to my population for building an hospital, which people can see. But talking about the system is very difficult to understand. So all presenters and all our speech from yesterday is going on the system, on the process. So my question is how to move from the process to the concrete action. Thank you very much.
So we thank, okay, the last one.
Good morning. First of all, I want to say that it's good that we are having this conference again to talk about PAC. But the question will always be, like Dr. Wang said in his presentation, you get to this facility, you see only one staff, having so much workload, and no assistant. He said he asked her, what do you need? I need human resource. We've been proposing this for years. The core regulators, who are the government institutions, receive some of these recommendations and guidelines and operational procedures. But yet, no measurements, no monitoring, no improvement. And so I think we also have to look at the role of regulators. As much as we, the technocrats, the economists, the experts, come up with diverse strategy to come out of the problem of PAC, which we have agreed globally, that is the only vehicle that can take us to UAC and SDG. We need to focus more on the regulators' role. How are we tracking their roles and be able to provide feedback to them? Secondly, the role of community. It was in that place, that facility. That health worker is attending to population within the catchment area there. They also have a role, well informed, to be able to also demand from their regulators the efficiency in order for us to be able to save more lives. And so as we continue to deliberate, the roles of regulators, the roles of community, we should also expatiate on how we can broaden it to bring more efficiency. Thank you.
Thank you very much. Excellent questions. I'm going to throw them all back to the panel. I just want to add 2 questions to the questions we are throwing back to the panel. My first question is the issue of accountability. I'm talking of answerability and of sanctions. Accountability for PHC and UHC performance for the financing. I think it touches on some of what the speakers have said. Who holds the public bureaucracy to account for PHC and USC performance and financing and achieving the goals we keep talking about? Because I do not think we can assume that the public bureaucracy is a disinterested, neutral party. They are also an interested party. Who holds them to account? I just want to ask that question. And then the second one is, as I listened through the presentations, it looks like all our countries are donor dependent to one extent or the other. Some of it came out in Dai slides, it came out in Hong slides. So what happened, and in some of the country level slides from Nigeria, from Cote d'Ivoire, you could see a multiplicity of programs. Again, my question is, given this multiplicity of programs, to what extent is there agenda fragmentation? To what extent are there synergies? And how much control do the countries really have to steer this vehicle on the UHC-PHC road versus some other road? So I would like to throw that in there now and give the panelists 5 minutes each to respond. And I think you have microphones. We are checking the time of the session. It's 10. The session ends at 10. 10:30. Okay, so we give the panelists 5 minutes. Then you do have 5 minutes to respond. Okay, thank you.
Okay. All right, I'll just briefly touch on some of the issues that Renee raised. In the first slide that I showed, but I didn't speak to it, I tried to indicate that I was focusing very much on primary level services rather than primary healthcare in its fullness. But I completely agree, Renee. I mean, we've got to be a lot more radical if we're focusing on primary health care. I'm sure you have more of the answers than I do, but I do think that it's both at the national level and the community level that there is a lot more that the ministries of health could be doing in engaging around the policy decisions of other departments. So looking at decisions around trade and industry and inputting to that. But we do need massive capacity to be able to do that. And I think that certainly from the South African experience, some of the civil society organizations have played a much more critical role than the ministries of health. I don't know how we break the mold of the focus on the health service. But it relates a bit to what Irene was raising about accountability. Certainly in the South African context, I think that civil society organizations, where they build capacity around specific issues, can play a massive role at that level. I'm not I'm not an expert in relation to community workers, but I do think that certainly community health workers have made massive contributions. And if one is going to adopt a primary healthcare approach and really engage with the social determinants of health, then yes, potentially we should be looking at community change agents or community workers that have a much bigger, a much bigger brief. But yeah, I think that you've raised, and people who spoke afterwards about the social determinants, I think that, a lot more should be done about that. I think that it would be, I think that community workers are undervalued and are not given the resources that are required. And for them to actually be able to contribute to changing issues around social determinants within their communities, we do need to have dedicated kind of funding for them. So yeah, that's all I'll say. I'll leave the other questions for colleagues.
Yeah, thank you very much. One of the things coming up from this session is the role of primary health care in moving towards universal health coverage. From the questions, what is the role of regulators? It's important for us to know that primary health care, for me, is a public good. So the government has to invest in it. The government has to take the center stage. And what kind of center stage do we expect the government to do? We need to ensure that we have the right resources. We also need to ensure that we set the stage in terms of what has to happen at the primary health care level. We need to understand that it will embrace both prevention, both promotive, rehabilitative, and even treatment. We also need to ensure that the health facilities where people go to access these services are in the right shape, with the right infrastructure, with the right human resource for health. This is some of the roles the government will play. Of course, the essence of community participation is to ensure that there is good partnership between the community and the healthcare system such that they will define what their problems are, what they need for them to have good health. And this encompasses the multi-sectoral approach. We need to look into the issues of water and sanitation. We also need to look into the cultural context that affect health. So I believe the government can set the stage by also ensuring that there are certain indicators we need to track to ensure that people are on the right track. Like they said, what is not measured, what is not recorded, cannot be tracked and cannot be counted. So we need to set the right kind of indices. We also need to look for ways of incentivizing those that are doing well. And more importantly, it's not about access to service, it's also about access to quality service. So in going forward, government needs to do something about it. The civil society organizations are the watchdogs of the society. They also need to come out and say when things are not doing well or not going the right way. The academia, we need them. We have been talking about all the right things in this workshop. When we get back, we expect them to make sure that this work. And the only way to do that is by publishing whatever we have, making noise about it, involving the media, so that everybody can stand up. Yes, in politics, they believe in hard infrastructure, but let's start looking at the soft infrastructure, and that's the people. So let's make sure that no matter what we do, the people will count. Let it be patient, let it be people-centered primary healthcare service. Thank you very much.
Merci. Peut-être en réponse aux questions qui ont été posées sur le district. Pour que les districts soient fonctionnels, il nous faut avoir des renforcements de capacité de ces districts-là en matière de ressources humaines, des ressources matérielles, des ressources logistiques. des ressources financières pour leur permettre de pouvoir gérer de façon optimale la mise en œuvre des interventions sanitaires, des soins de santé primaires et suivre l'amélioration des résultats. Et cela est très important, d'autant plus que ces districts-là sont le lieu de la mise en œuvre des soins de santé primaires. Aujourd'hui, avec le profil épidémiologique de l'ensemble des pays que nous constatons, on l'a dit tout à l'heure, nous avons l'émergence des maladies transmissibles. Nous avons une persistance des maladies, l'émergence des maladies non transmissibles et une persistance des maladies transmissibles. Et la question des déterminants sociaux est importante de pouvoir prendre en compte puisque la plupart des facteurs de risque ne sont pas forcément dans le secteur de la santé. Il y a nécessité de pouvoir établir une forte approche de multisectorialité pour discuter avec les autres secteurs et voir comment on peut adresser ces déterminants sociaux de la santé et les prendre en compte également. Un autre point, à travers cette approche multisectorielle, je pense que le partenariat prend également tout son sens, puisque les autres secteurs doivent pouvoir communiquer, dialoguer et voir comment on peut adresser la question de la santé dans les autres politiques publiques sectorielles. L'hôpital, c'est vrai, Dr Moussongo, il apparaît très visible, mais les interventions qui sont faites au niveau de l'hôpital semblent être coûteuses pour la plupart des populations. C'est pour ça que les soins de santé primaires qui sont démontrés comme coûts efficaces sont plus recommandés pour pouvoir permettre aux populations les plus reculées, même les plus vulnérables, de pouvoir avoir accès à des soins. Pour le cas de la Côte d'Ivoire, je pense à la question que le professeur Aguemong a posée, ce qu'on a fait, comme je disais tantôt, c'est vrai que c'était l'hospitalocentrisme, celui-là un peu toujours, mais la politique sanitaire est fondée sur les soins de santé primaires. Il était nécessaire de pouvoir ramener ces éléments-là de façon claire dans la mise en œuvre, et c'est pour ça que le gouvernement s'est penché sur l'amélioration de l'accessibilité géographique, l'opérationnalisation des districts pour être capable de suivre la mise en œuvre de ces soins de santé primaires et un focus aujourd'hui sur comment est-ce que le financement de la santé puisse être amélioré pour avoir une opportunité de mieux financer les soins de santé primaires avec des dépenses publiques qui sont plus orientées vers les soins de santé primaires. La question de la régulation également est très importante. Il faut pouvoir faire en sorte qu'à travers les ministères de la Santé, tout ce qui a été défini comme norme, comme standard, puisse être appliqué pour que les soins qui sont menés soient de qualité, qu'ils puissent, à un moment donné, prendre attache avec les données et se rendre compte que s'il y a des inégalités, il faut être capable de les adresser avec des recommandations et des stratégies à développer. Voilà. Merci.
Thank you. There's a lot of excellent questions. I'm trying to address it from the three aspects. The first way is political commitment. Primary health care matters for everyone, for every population's health, everybody's health. So we knew there's a huge political commitment. And from Alameda to Astana, almost every politician will say, I'm committed to improve primary health care. However, if you look at the investment, it's not there, right? So 40 years ago, when started Alameda, there is no tracking system. How people invest on primary health care, how people actually action on their political commitment. I always say, as an economist, I would say, political commitment without funding support is empty commitment. We don't want this empty commitment happen again. So investment on primary health care should be trackable and it should be observable and should be taken accountable for people responsible for primary health care development. The second way is about the management issue. Someone raised the fragmentation issue. It is true that the primary health care system is very fragmented. It's almost in every quarter, every village, every community, every town centers. So it's unlike hospital, it's a large scale. So, and in addition, the service is very fragmented. The development partners is very fragmented. And the system is suffering fragmentations. So how do we build a strong management system and make it performance efficient, effective is very, very critical. And it's not just about a policy at the national level. We need a strong district management system in place that are able to manage this fragmented service delivery system. Very critical. The third one is about action. There's no one-size-fits-all. It's hard for any of us to say, how do we change, how do we translate policy, framework, concept into action as one-size-fits-all model. That's why we need this type of conference. We need to have a learning, a peer-to-peer learning program, like the foundation invests the joint learning program, this Africa Observatory, this strategic purchasing platform, centers. So this is really create a learning platform to enable people exchange their talents, their experience, their lessons. So we're not able to answer this specific question about how to do that, but the answer should come from all of us that are actually doing day-to-day work and doing and translate all this policy and the framework and the concept into action. Thank you.
Thank you very much for your excellent questions. In fact, they are not questions, they are informed comments. And all the questions point to one thing, that we should not expect different results if we continue to do things the way we are doing. And to start with, we need a new mindset, a health determinant mindset. We need a mindset that starts to look at what are the cause of the causes, not just treat a disease. We pay a lot of lip service to intersectorial collaboration. But look at us in this room. We are all mainly from one sector. How many people are from other sectors in this room? When the SDGs were being negotiated, most people argued we need an health SDG. Some of us said we need to make sure that all SDGs are health SDGs. All health, we should not say only SDG 3 is a health SDG. And yet you hear people saying that this is our SDG. All SDGs are health SDGs. You also made a very good point that Africa will not achieve universal health coverage as long as we depend on others to provide us with resources. The answer to universal health coverage is domestic resources. It's not external resources. And Africa will not achieve universal health coverage unless we pay attention to traditional medicine. We have not done that. We've paid a lot of lip service, but we haven't done very well. But the fundamental thing that was raised is we will not achieve universal health coverage unless there is public ownership. This is not for us as health professionals. Unless there's public ownership, unless we are transparent, unless we are accountable, and unless we change our patronizing nature to patients and to local communities, that is where we'll make progress. So thank you for reminding us about the importance of not doing business as usual. Thank you.
Thank you very much. I want to throw a question back to the panel. And in fact, Dr. Samwaba made an important point that we are now fashionable. When I say we, I mean the theme of this conference. Primary healthcare is fashionable again. I think Dr. Leju mentioned from Alma Ata to Astana, the next big conference. And he also made the point that in health, just like in fashion, fashions come and go. and so it's not going to be fashionable forever. How do we make sure that now that primary health care is fashionable, universal health coverage is fashionable, the world moves forward before it becomes no longer fashionable? And I would like to throw the question back to the panel. What can we do differently? Because we've done business as usual since Alma Ata. We've done business as usual, both when it was in fashion and when it went out of fashion. So what do we do differently? And I would like to ask the panel, what do we do differently? And I'll also invite the audience, if you have anything to say. Yes, what do we do differently? And please feel free to be as provocative and as outrageous as you want to, politely and with courtesy. Because sometimes if you don't rock the boat, you don't move. Thank you.